el presidente, Dr. De Leon también. Pero mi español es muy malo, so más inglés aquí. So. Today I have 3 lectures, mostly focusing on bone defects and how we manage them. So the first one starts out a little more academic, and then it becomes very case-focused with muchas fotos. Es muy bien. So. But I am in private practice in Portland, Oregon, in the Pacific Northwest. It's very green, a lot of trees and volcanoes that do not erupt. But you know, I did 2 different fellowships. One in acute orthopedic trauma, did a lot of acute internal hardware, plates, screws, nails, and then I did a second deformity fellowship or a reconstruction fellowship in Manhattan across the country, dealing mainly with kind of chronic deformity, like length discrepancy, things like that. My practice today is a lot of in between, dealing with infected pilons, you know, subacute bone defects, and more kind of subacute issues. But I use a lot of frames and lengthening nails. So today, this first lecture is focused on kind of managing how we manage bone defects in my practice in the United States. So there are some classifications. It's kind of a riff off of the AO classification on how to categorize bone defects. This is done by Tetsworth, who lives in Australia. It's basically a continuation of the AO classification, helpful for research papers and just trying to get a sense of, oh, how big is a big defect? But kind of general methods of fixing bone defects, I kind of categorize in kind of 2 different columns. One is with distraction osteogenesis, or growing new bone, and one is non-distraction osteogenesis. And so on the left column is how we were kind of traditionally trained, most of us, you know, mostly bone grafting, whether that's, you know, Mascalais or acute bone grafting, or struck grafting. That's a fibular vascularized allograft, autograft, or now we're doing more kind of 3D metal cages. What I primarily focus on is more biologic distraction osteogenesis, and we'll kind of focus on this right column of the frame, plate-assisted transport, and then the transport nail. And then there's another concept I call backdoor transport, which is kind of a shortening and then lengthening later, which I'm sure all of you guys have done before. So just to review Mascalais, it's typically a 2-stage procedure. The first is debridement. You get rid of all the bad bone, and you put a cement spacer with antibiotics to create this pseudomembrane around. And then stage 2, typically 6 to 8 weeks later, you go back in and bone graft, typically depending on the size of cancellous allograft, autograft, and sometimes antibiotics as well. Struck grafting, just to kind of go through all the options, is traditionally cortical grafts taken from a cadaver bone. Better is likely a vascular graft if you have access to that. It would be like a free fibula vascularized graft. And then now people are 3D printing titanium cages, which graft can go inside. So there's some new up-and-coming strategies to do that, and I think there's some advantages of that, but in the correct patient. So, you know, how do these bone defects typically occur? Most of the time it's high-energy open fractures. A lot of time it's a result of infection osteomyelitis, ballistic trauma, failed fixation, or in the oncology world, tumor or non-union resection. So going over the 3 kind of forms of distraction osteogenesis, a lot of different ways you can do it. One is at the frame. And I'll show you some modern techniques of how we do that. One is called plate-assisted bone segment transport. It's where you have a plate that's stabilizing the length, and then you're transporting a segment with a motorized nail. And then there are these specialized nails that kind of all-in-one, all-internal, able to transport a segment within a fixed construct. And those have quite simplified some of these cases, but are not always available, including my practice. I don't have access to a transport nail. So just to get people familiar with some of the terms of transport, we talk about how many segments we transport, what direction, how we do it, and then some specific techniques on how we do it safely and effectively. So here, when we talk about a bifocal transport, it doesn't mean there's two segments moving. It means there's one segment moving where you have an area of distraction, making new bone, and another area where you're filling in the gap. This is your quote-unquote non-union, and you're filling in that gap. So to go a little more advanced, trifocal doesn't mean three segments. It means three areas of activity. So you have distraction here, and then filling in this gap here. And then you can have what we call tandem, so these two are going the same direction, versus converging, which these are meeting in the middle, versus diverging. There's certain situations where you have a vascularized segment in the middle, and you split it to fill in the top and bottom. So requirements for good regenerate, you want to preserve the periosteum. Old school thought, back from Elizarov, was you had to preserve the endosteum, but we're using a lot of motorized nails these days, which are all intramedullary, so some people are questioning that. You need a stable mechanical environment. Some people think that fractures like to heal in compression and compression only, but distraction reduces the shear, which improves your mechanical environment for healing of that distraction. And then obviously you need a healthy soft tissue envelope. And this comes into play with your plastic surgeon as far as, my first priority in these big reconstructions is I need a closed, non-infected limb. And sometimes that can be a challenge as that first step before you reconstruct the limb. So here, techniques for making an osteotomy. Traditionally, I was taught with the De Bastiani technique, multiple drill holes completed with an osteotome. There's some other ones that I'm not trained in, but I think are useful. Would be the Gigli saw, the Gigli saw, and in some cases an intramedullary saw. Can be very percutaneous. This is a study that came out about a year and a half ago, basically combining bone transport with mascalade. They found out that if you had mascalade, stage 1, put a spacer in and had this pseudomembrane, that rates of union at the docking site were improved if you had a mascalade done before. So they had faster docking site non-union rates, lower non-union rates, lower infection rates, lower additional surgeries, and no difference in how long people were in the external fixator. So I thought that was helpful. So going a little deeper into some of these techniques. So this is traditionally kind of frame transport. Here you see this segment is connected with Chance pins that transport the segment directly down. Taking that up a level, Dr. Quinnen in Florida had theorized and came up with this technique to do balanced cable transport, where a cable is routed through the segment, and that drags like a horse and carriage down and around to pull this segment down. So here's your osteotomy up here, bringing the segment down to fill this defect. This is just a temporary spacer. So, and I'll show you how I've kind of advanced on that topic. The problem with these traditional techniques are very related to an external fixator, and I'll show you some tricks later. The second option is this plate-assisted bone segment transport, where now your length stable is through this plate across, and you're transporting with a motorized nail. So this is termed Pabst, which is a common, very cheap beer in the United States. And then you have your transport nails, which have a slot in them and motorized to transport a segment straight, but maintaining length stable there. So here is a schematic of kind of next stage. Here we're automating our transport frames, and this is what's gotten a lot of attention recently. And so now, instead of just doing one segment, we can start doing two segments. And there's a whole nother lecture on how we rig these up to allow this one to move twice as fast as this one, so you get relative same distance and then your distraction rates. Very, very simple, very easy mechanical ways to do this, but intimidating to look at first glance. And now converging, here's the model for that, where we're meeting in the middle. These are all filmed in my kitchen, by the way. That's why I'm still a bachelor. And now we're doing it trifocal with internal lengthening nails. And this would be more of a PAPS type case. A couple different ways to do that. And here playing with the idea of not cables, but using sutures, which are just as strong. So that's segmental bone loss. Perfect. I think we'll go straight into my second lecture, and then we'll have a guest speaker for in between my second and third. So we can load up the circular external fixator.